Now we move on to the next speaker. Welcome Dr. Saprishi Bhattacharya, who has joined our department, Apollo Center for Obesity, Diabetes and Endocrinology a few days back. We welcome Saptrishi Bhattacharya in our department, and he's the next speaker. Over to Dr. Saptrishi. Your time starts now.
Thank you, sir. Thank you for the warm welcome. I would first like to thank Dr. Khanna for giving me this opportunity, and also Dr. Wangnu for welcoming me to the department as well as giving me this opportunity, and also congratulate Dr. Khanna for organizing such a wonderful conference. So I will be discussing about cardio-renal metabolic approach to type 2 diabetes management, and whether the SGLT2 inhibitor DPP4 fixed drug combinations, they actually help in the management of type 2 diabetes or not, and how they help. We'll be discussing it over the next 10 minutes or so. So if we look into our patient profile, so it's a Mr. D, a hypothetical patient, 43-year-old, diabetic for 2 years, HbA1c is 8.6 on metformin 1 gram twice daily, hypertension, dyslipidemia, typical profile which we see in diabetes for cholesterol, uh, obesity, NAFLD, microalbumin. So these are very, very common patients who just walk into our clinics day in and day out. And we usually, many of us tend to follow a very slow and graded approach. And okay, if you are not getting controlled on metformin, let's try DPP4 or a sulfonylurea. And we take a very slow and staggered approach. So do we need to change that? So how is the recent evidence evolved over the last few years, and how our management and approach to diabetes should change? And it should not be focusing on just numbers. We should actually be looking into the outcome of patients rather than focusing on numbers. And so the answer actually lies in the natural history of diabetes. So if somebody is having diabetes, he already has a long history of hyperinsulinemia, where the metabolic changes in the system have already started taking place. They already have macrovascular complications, sometimes even in the advanced stage, and many of them actually remain undiagnosed and do develop microvascular complications. And when somebody gets diagnosed with diabetes, actually almost 50% of the beta cell function is lost. And in spite of the best treatment we offer to our patients, we see that almost globally only 30% of the patient, or maybe 33% of the patient, actually reach a adequate HbA1c target. And also in India and Southeast Asia, even the numbers are even worse. So we say it's not about only, and there is a huge burden of complications. So whatever treatment we give to our patients with diabetes, so there are so many patients who turn up with cardiovascular disease, heart failure, chronic kidney disease, even NAFLD has evolved as a very important complication. So all these complications have a high prevalence rate in the setting of diabetes. And it's not about the HbA1c number, it's the metabolic milieu which is actually contributing to the complications arising from diabetes and related metabolic state. So specifically, we'll be talking about the cardiovascular, renal, and metabolic aspects, and we know that they're all interrelated. So heart is the most metabolically demanding organ. Again, liver actually controls our metabolism, and along with pancreas, we all know. Kidney also plays a very important role in glucose and volume homeostasis. So dysfunction of the heart, kidney, liver, metabolism, they're all interrelated. So if one of them gets dysfunctional, the other also gets affected. So we know the mechanisms behind that. So the learned cardiologist will be knowing more than me on these aspects. So how if somebody who has CKD is predisposed to cardiovascular disease. If somebody is having diabetes, we all know that is predisposed to cardiac disease. Even somebody having renal dysfunction, or if somebody is having a cardiac disease, how it alters the metabolic state, how it causes insulin resistance, how it increases inflammation. So all these actually are very closely interrelated. And our focus should be shifting from, rather than a glucocentric approach where we look at only the HbA1c values. We should be actually looking at a more comprehensive way of managing diabetes, where we analyze the patient characteristics, consider the specific factors that actually should affect the treatment, take the patient into confidence in the decision pathway, and implement and monitor the management plan, and also review it accordingly. So we should be moving from a specific, measurable, achievable, realistic, and time limited approach for diabetes management, which is a smart way of dealing with diabetes. So that is the practical way of doing about it. If we slightly move into the pathophysiological aspect, so we have moved from the concept of insulin secretory defect and insulin resistance in diabetes to the ominous octet, where we know that there are multiple mechanisms. So these are the 8 which we know about. There will be many more. I think subsequent research will show light on that. But we are not dealing with only insulin. There are multiple aspects to diabetes management, and the OHAs, actually some of the OHA, one OHA will take care of 2 or 3. So if we are able to introduce multiple OHAs without aggressive glycemic target, but if you are giving insulin or sulfonylurea, most probably you won't be able to do it, because the person will end up with hypoglycemia, and your glycemic target, so you cannot achieve, sometimes might not be able to achieve a HbA1c of 6.5 without causing hypoglycemia with sulfonylurea. Sometimes it does happen. So if we have these newer molecules where we are able to approach not only the glycemic aspect, but along with glycemic aspect, as Dr. Dheeraj was telling, that if we take care of the renal part, the metabolic part, the weight part, the blood pressure part, as well as the cardiovascular part, so obviously that will overall offer the patient a longer and more productive life. So theoretically, SGLT2 inhibitors and DPP4 inhibitors are complementary to each other. We all know that as blood glucose goes down because of renal glycosuria, the glucagon level goes up, and theoretically DPP4 inhibitor actually should block the compensated rise in glucagon. So initially there was a lot of enthusiasm about this combination, that it might have a synergistic effect. So what in the trials it came up was, did not actually have a synergistic effect on glycemic control, but it did have a overall beneficial effect. So if you combine the two molecule, you do not have the side effect of hypoglycemia unless there is some other agent like insulin or sulfonylurea, and you have a higher chance of achieving the HbA1c target, as well as you can decrease body weight. That will be primarily because of the SGLT2 inhibitor. You can also decrease blood pressure and boost the systolic diastolic. And Dr. Dheeraj has been talking about it extensively. So we have, after a very, very long time, we had very encouraging results from the SGLT2 inhibitor cardiovascular outcome trials. So empagliflozin, canvas, which EMPA-REG was a trial for empagliflozin, canvas for canagliflozin, and declared TIMI for dapagliflozin. So there was reduction in 3-point MACE in 2 of these trials. The renal outcomes also improved. CV death was significantly improved with empagliflozin. Hospitalization for heart failure, as Dr. Dheeraj has been discussing, was actually significantly improved in all with all the 3 molecules. So what we know is that the SGLT2 inhibitors, they have a tremendous beneficial effect on cardiovascular outcome, and we even have dedicated trial or now from for the gliptins. We have trials of saxagliptin, sitagliptin, linagliptin, and even like for allogliptin as well. So what we see was that there was only a slight doubt about the hospitalization for heart failure with saxagliptin, but all the other gliptins were remarkably safe in terms of CV death, 3-point MACE, or renal outcomes. There are some evidence it might be even slightly beneficial in reducing microalbuminuria also. So SGLT2 inhibitors, as we all know, it has a strong beneficial effect on cardiovascular outcome. DPP4 inhibitors are remarkably safe molecules and are very well tolerated, are have been in the market for almost 15 years, and they have been tried and tested in our clinical practice. So the combination actually does wonders without causing hypoglycemia, and it carries with it all the beneficial effects that the SGLT2 inhibitors provide. So we were discussing about the kidney outcomes. So there are multiple dedicated trials as well as kidney related data has been extrapolated from cardiovascular outcome trials, where it was shown to have a strong beneficial effect on the composite kidney outcome. So all patients, even there are studies with dapagliflozin which show that even in the absence of diabetes, there is a beneficial effect on the kidney outcome. So SGLT2 inhibitors are molecule which not only improve the cardiac outcome, they also have a very strong effect on kidney outcome. So all our patients who have, say, GFR in the range of, say, up to 30, more than 30, or somebody is having microalbuminuria, macroalbuminuria. So unless there are contraindications or the patient is not tolerating, should be on a SGLT2 inhibitor and provides one of the strongest nephroprotection. So even maybe better than AC inhibitors or ARBs. So these are molecules which have evolved over time. So they have shown to have cardiac benefit. And doctor, I am not going to go into the details of it. Dr. Dheeraj already elaborated that. In fact, the SGLT2 inhibitors are the only molecule which actually did show benefit in terms of overall outcome related in persons with preserved ejection fraction. So this was impaired preserved was a trial where patients who had ejection fraction of more than 40% were included, and there no other molecule actually have benefited this group of patients. And this molecule happens to be unique because it did show benefit even in this group of patients. So this is a very promising and encouraging molecule. So we have evolving data, not very large trials as like the dedicated CV outcome trials, but even we have evolving data related to NAFLD, that it decreases the hepatic fat content. There are even markers of improvement in histology associated with SGLT2 inhibitor usage in the setting of NAFLD. So heart failure, Dr. Dheeraj has discussed in detail. So for SGLT2 inhibitors, there are slight doubts about the for DPP4 inhibitors related to saxagliptin, but again that is a controversial issue whether it actually does it or not. So there are different schools of thought that it was because of patient selection and other factors as well, but some slight doubt about that. But otherwise it's a remarkably safe molecule, multiple positive outcomes. So empagliflozin linagliptin is is the most commonly used, I think, the SGLT2 DPP4 inhibitor in the market. We also have dapagliflozin and saxagliptin in India. Artugliflozin and sitagliptin is currently not available in India. It's available in US and some of the European countries. So these are the molecules which are available, and most of the combinations do show remarkable benefit in terms of 3-point MACE, CV death, hospitalization for heart failure, as well as renal outcome. And additionally, again, the number of patients were not that many. So there are some evolving data which suggests that the combination actually can improve the genital infection and urinary tract infection associated with SGLT2 inhibitors. So numbers are not that many. So these are early data related to that. So the hypothesis that was proposed was that DPP4 inhibitors alters the lymphocyte function, and that might have a protective effect on the urinary tract or genital infection associated with SGLT2 inhibitors. So, but again, these are early data, but we do have some early evidence which suggests that a number of episodes of vulvovaginitis, balanitis, or urinary infection actually does go down. So for a patient like this, we need to look into the management of glycemic control. Not only that, but we need to look into the cardiac, renal, as well as metabolic aspects, including NAFLD, and consider this combination very early in the course of management. So the combination has multiple pathophysiological benefits: high efficacy, early achievement of glycemic control, low risk of hypoglycemia, weight and BP reduction, cardio protection, renal protection, and usually a very well tolerated molecule, and also additionally it has the advantage of increasing compliance. Thank you for your patient listening. I now hand over the mic back to the organizing team. Thank you.
I think, thank you, Dr. Saptrishi, for a wonderful talk. And we will have a couple of questions at the end of the whole cardio diabetes symposium.